Welcome to everybody who's already jumped on. We're just going to wait another couple of minutes because there are quite a few people jumping on now, and then we'll kick off. Hello and welcome everyone to today's webinar, Join the Pre-Employment Revolution. I am Rebecca Stevens and I have the pleasure today of introducing you to your presenter, Lisa Anderson, who's the Principal Consultant at Direct Health Solutions. Just to give you a brief background on Direct Health Solutions as an organisation, we've been the Australian leaders in the absence and injury space since we were founded in 2005. And we're the largest telehealth company in the country with sophisticated up-to-the-minute cloud-based technology underpinning our absence, injury and medical programs. Our 24/7 contact centre is staffed with allied health professionals and we handle over 500,000 calls annually. We also have a network of over 4,500 medical providers in the occupational health space. Lisa herself has qualifications in occupational therapy and OHS management. She's worked in health safety, injury management and personal injury compensation for nearly 20 years in a variety of different roles, both employer-based and consultancy. Lisa brings a wealth of technical knowledge to this space and has a real knack for translating complex ideas into really simple solutions that are easy to implement. So we're really lucky to have her speaking today. Just a couple of quick pieces of housekeeping before I hand you over to Lisa. There's been a fairly big response to today's webinar, so in the interest of keeping everything timely, because we know you're all busy, we've got the audience on mute. If you do have any questions or comments, however, we really strongly encourage you to use the chat or the Q&A box, and we'll try to get to as many questions as we possibly can at the end of Lisa's presentation. If there's anything that we are unable to get to, then we'll come back to individuals, and then if there's anything that's sort of specific to your organisation, we'll come back to you as well. Thanks everyone, and now Lisa, I'll hand it over to you.
Thanks very much for that, Beck. As Beck said, we're very aware that everybody is very time poor. So we did commit to a 30-minute session today, and we will do our utmost to get through the content we've promised and also allow a few moments for questions at the end. So please do, as Beck said, shoot through your questions as we go through, and we will try and get to those at the end of the session. But just by way of kick-starting today, really the key outcome we would like you to walk away with is some ideas about how you would like to optimise your own pre-employment program internally. So specifically, we will be going through 4 key sections. 1 around the predictive value of pre-employment assessments, 2 around the market evaluation of approaches to medical assessments. The 3rd pillar we'll be looking at is how to improve the reliability and validity of assessments. And finally, we'll be wrapping up with some recommendations around program design factors to optimise wellbeing and productivity across your workforce. It's always important to come back to why do we actually do pre-employment screening? And if you look at the literature, if you receive any legal advice, if you consider your own business position, it will generally fall into any combination of these 6 factors. One is to ensure the applicant is able to perform the inherent requirements of the job for which they are applying. 2, to assist in identifying the need for reasonable adjustments to be made to allow the person to perform the role. 3, to identify potential future risks to the health and safety of the applicant or other employees, equipment and/or property. 4, to reduce the costs associated with absence from work, loss of productivity and turnover. 5, to comply with obligations under work health and safety legislation. And 6, to aid the determination of insurance and superannuation entitlements. All of this is in the context of the economic landscape faced by many employers today. Increasing litigation, increasing workers' compensation premiums, bigger impact on life insurance policies and superannuation funds. Some industries mandate assessments, such as transport, mining, oil and gas, etc. And some particular risk exposures mandate assessments, whether it's noise, asbestos, lead, etc. But all that said, there is actually very little empirical evidence in support of pre-employment examinations relative to either economic or health outcomes. And you're probably a little surprised to hear that coming from a provider of pre-employment assessments, but that will become clearer as we go through today's presentation. The default use of clinical assessments is often driven by a compliance mentality or simply a reticence to shift from what has always been done. We've always done medicals, therefore we need to continue to do them. Today's session will provide you with some alternatives to consider that reduce investment and increase the effectiveness across all of these objectives. In order to do that, we need to evaluate the predictive value in the context of the full employee life cycle. Obviously, employees join an organisation and at any point in the life of being with that organisation, things can occur to upset the baseline, be it illness, injury, an incident, a change in circumstances, personal, work-related. All of these things have the potential to adversely impact attendance, productivity, compensation, be it workers' compensation premiums, group superannuation policies, and then there's also the hidden costs of reputational damage and business continuity, all of which provide adequate motivation to not just know, but also understand the risks walking through your door. In order to understand what affects the predictive value of your assessments, we've gone to a lot of literature, and the overriding theme is that the failure to identify or identifying very weak pre-employment predictors of health and work is the primary factor that you will not get the information you need to make that decision relevant to the person within their work role. So if you look at the 2 major factors there, one is health, often related to irrelevant medical history or having poor clinical guidelines to make decisions. And 2 is around the job-specific inherent requirements not being understood or not being aligned to the assessment. The health standards required and criteria for rejection of applicants should be based on a full risk assessment of the prospective post. To give you some case examples to put that into context, there are data-driven predictions that are readily available to any medical professional who's conducting a pre-employment assessment. We know smoking has an increased risk of work-related injury. We know alcohol and substance abuse has increased rates of disability. However, just because someone demonstrates the habit, does that constitute adequate reason to not employ? And how much constitutes abuse? In what circumstances? And what are the parameters for acceptable employment? And does it relate to the role at all? It opens a myriad of questions. Similarly, when you look at factors like alcohol and substance abuse, when it's combined with mental illness and or chronic physical illness, we know that the rates of disability start to increase even further. With common medical condition, there's often no standard criteria to determine fitness for work. A simple example, hypertension. One industry may set a limit at a different level that another industry may set. So is that threshold driven by medical justification, or is it driven by the political influence that that industry has had on that assessment score? But all of these factors need to be taken into account when we're looking at applying the predictions around that initial medical assessment. A similar example, really basic medical condition, anaphylaxis. Firefighter who works out in the field, is that person safe to be out there with the risk that once in the past 10 years they've had an anaphylactic response? Are they safe to be out there? Who makes that determination? And based on what justification is that decision made? It's really challenging for medical practitioners. It's even more challenging for employers who are trying to interpret the risks that the doctors are trying to articulate. Another really common factor, previous history of low back pain. If they have comorbid depression, they're going to have higher absence from work. Once again, how do you evaluate that? How do you determine what your appetite is to accept that person into the workforce? Workplace violence, common issue at the moment, high profile, many work cover authorities driving home the need to identify and reduce the risks around occupational violence. Interestingly, the literature would suggest that standardised screening has not fared well in predicting people who are going to act on these behaviours. The strongest prediction has come from a history within the workforce, i.e. your reference checking as you go through the recruitment process. So as we move on to what's actually happening within the market in that context, you look at any providers of medical services and they will offer online questionnaires, telemedical reviews, clinical assessments. Within the clinical assessments, there's anything from standard medicals to your specialty tests, to drug and alcohol testing, to functional capacity evaluations, to psychometric testing and specific tools around resilience or safety culture or whatever has been identified by an organisation. The other critical factor occurring out in the market is the fact that these interventions can occur at pre-employment, during employment or post-employment phase. From an assessment delivery perspective, the providers delivering these services are doctors, physios, nurses, psychologists, OTs, exercise physiologists, pathologists. Locations can be clinic-based, on-site, in a workplace, telemedically or online. The different tools that are getting used, anything from generic, custom-built, clinic-specific, employer-specific, industry standard, or standardised assessment tools. Once you overlap those three layers, they all have the ability to affect the critical factors of the program experience and outcomes: timeliness, the cost, the effectiveness, the consistency, the convenience, and the quality. In relation to the practitioner's experience of delivering pre-employment medicals, there's been a significant paradigm shift in the way these medicals have been delivered over the past 20 years. But unfortunately, this hasn't really improved practitioners' feelings towards them. So if you ask most doctors, they will still say pre-employment medicals are unpopular. They find them a nuisance. They see them as high effort for low reward, highly paperwork driven. There's significant legal implications. A lot of paperwork has quite confusing evaluation matrices to complete. And at the end of the day, the doctors are time for themselves. They don't have enough time to review the candidates' responses, to review the specific assessment requirements and prepare themselves to get the most out of that face-to-face clinical appointment. We've included a table here to compare how medicals were delivered in the past and the pressures that are on doctors today. So they've really moved from that static assessment approach to having to be more dynamic and respond to those customisations. Previously, really the only modification to an assessment was the practitioner experience. Now they're driven by system protocols, system guidelines. There's an expectation that they have clinical knowledge and expertise across all of these different factors that we're talking about. They've moved from paper-based systems into online systems in some circumstances, and certainly to the future, that is where the industry is heading. In the past, they could very much rely on their own personal professional experience. Now they have access to an innate amount of online resources. In the past, they would complete the assessment, sign off the form and return it. Now there's an expectation that they link into preventative health. And some doctors are actually appreciating that opportunity to feel as if they're doing something positive in that person's life to assist them with their well-being. There's also, with the focus on shifting towards risk assessment for medicals rather than a pure yes-no outcome, it's put a lot of pressure on the doctors to actually understand the risk matrix that they're expected to use. Hence the experience that we hear about them feeling confused about different evaluation scores, different tools that they're expected to complete to the employer's expectations. The other important paradigm shift has been around the legal implications, and with increased litigation obviously becomes increased fear for anybody involved in this process to ensure that there is reliability and validity in the assessment and justification of the outcomes. So speaking of reliability and validity, it would be negligent not to include a section to address how this is faring in the market today. So just as a background, validity refers to the accuracy of a measure. Does it actually measure what it says it measures? Like a thermometer, everybody knows a thermometer measures temperature. If you try to use it to measure something else, it would not be valid. You also need to consider how that measure translates to the real world. And is it a reasonable extrapolation of the test results from a controlled environment? Is it verified by data? As opposed to reliability, which refers to how dependable or consistent a test measures a characteristic. If the candidate takes the test a month ago and repeats it today, will he or she get a similar test score? The test taker's temporary psychological or physical state, as well as environmental factors, can influence the results. Reliable assessment tools produce dependable, repeatable results. And if we use this in the pre-employment space, something like a spirometry test, as long as the machine is calibrated and the environmental demands are consistent, you would expect repeatable results. An example of a reliable tool. The challenge then becomes extrapolating the results in the context of the work environment. So what do they actually mean in the person's performance of the inherent requirements of the job? How does that translate to them being safe 8 hours of the day once they've commenced work under those equivalent pressures? And another example is if someone scores highly on a resilience metric, does that mean they will cope with the foreseeable demands of the role? How do you discriminate between the level of the type of resilience required for different roles? A police officer would require a different level of resilience to a cleaner. You could argue both require resilience, but how do you assess what that resilience is, and then how do you tailor the tool to assess to that level? Because getting a score out of 80 out of 100 might be the threshold for the police officer, but what is tolerable for the cleaner? The reality is that we still don't have adequate data to support the reliability and validity of pre-employment assessments, nor strong clinical guidelines to govern occupational health predictive factors. So we need to rely heavily on the experience within our medical community and not lose sight of the goal is that the pre-employment examination is to determine whether an individual is fit to perform his or her job without risk to himself or others. And that really comes down to our understanding of the inherent requirements of the role. And in order to do that, you do need to have a detailed assessment by role. We do recommend that it's rated against a standard, whether you use the Dictionary of Occupational Titles or you have another tool that you've found to be valid and reliable. It needs to be easy to interpret, keeping in mind the audience that's going to be using that. Because obviously the candidate applying for a role needs to be able to understand very easily what's involved in the role to be able to tell you if they think they're going to be able to perform those safely. The other person, the key stakeholder, is going to be your doctor or the health practitioner who's providing you with advice about that person's suitability. So with that audience in mind, it needs to be easy to interpret. It also needs to be aligned to internal documentation around safe work practices, return to work plans, suitable duties, etc., to aid you throughout the employment life cycle. And there needs to be a way to consistently apply those inherent requirements tables. And the best examples are where there have been a consultative process, it's involved full task analysis. There's been consultative forums or focus groups with the key employees, and equipment has been designed to measure exact forces, weights, heights to be tested to best replicate the work design. We must remember that the purpose of the pre-employment screening is to assess the person's ability to perform the inherent requirements of the role, any reasonable adjustments that can be made, and ways to mitigate the risks that may arise by reason of the disability or health concern. Which brings us to the program design factors to optimise wellbeing and productivity. The screen in front of you at the moment will not be foreign to anybody who has worked in health and safety. The concept of reducing risk as low as reasonably practicable is not new, but it's important to review this in the context of a risk-based medical program. As with any other aspect of safety, are we undertaking activities purely for compliance or for the betterment of the workforce as a whole? Remembering that wellbeing is not just the absence of disease or illness, it's a complex combination of a person's physical, mental, emotional, and social health factors strongly linked to happiness and life satisfaction. Sounds like lofty objectives for an employer-based medical program, but it's not completely unachievable. And the same challenges remain for any risk-based decision. What am I willing to pay for the desired level of risk protection? A recent study in the context of risk factors identified or predicting delayed return to work in the compensation space has some relevant findings to translate to medical programs. And we've just listed a couple here, and it really just consolidates what we've been talking about. The fact that the overarching principle behind identification of risk is that it will inform an appropriate course of action to achieve optimal work outcomes. The aim of risk factor identification is to guide evidence-based, transparent and consistent decision-making that is acceptable to all stakeholders. The method of collection, timing and interpretation of the information should reflect characteristics such as operational structures, experience and skill level of people involved. And finally, that risk factor identification must balance the ability to predict likely outcomes with the time frame, and we would also add cost, for effective intervention. I think what is most relevant about this research is that it does demonstrate the value of having a pre-employment program that can actually be able to be applied throughout the life cycle of the claim. So that consistency and that infrastructure gives you benefit not just at that point of employment, but ongoing through the employment relationship. Similarly, if we look to the World Health Organization for their position on pre-employment medicals, they have quite a simplistic approach to say any health assessment should be appropriate to the requirement of the role. Interestingly, their advice, and this was from a study back in 2009, so albeit a little while ago, medical exams are only justified when the job involves working in hazardous environments, requires high standards of fitness, is required by law, or when the safety of other works or the public is concerned. They go further in this document to actually recommend against physical assessments and to avoid drug and alcohol testing. What they do recommend is a shift into a questionnaire review process in line with all of the risk management philosophies we've been talking about today. And that's where their final recommendation on the page here is to satisfy duty of care without discrimination, you must undertake a case-specific assessment of risk. In relation to evaluating risk, no evaluation is complete without considering the commercial considerations. So this slide is to demonstrate that with any level of risk protection is typically an increase in cost. One of the points we are attempting to make today is that sometimes you can actually increase your level of risk protection through better planning and better delivery of a program whilst concurrently reducing cost, which is atypical. But at the bottom line, when you're looking at your pre-employment program, you need to understand what is your cost appetite, what is your risk appetite. Also in the context of the employment market and the role demographics. If you are in a tight employment market, you are engaging low salaried roles with high turnover of unskilled labour and therefore unlikely to reject candidates, an expensive pre-employment program is not for you. But that doesn't mean you can't have an affordable and effective risk review program in place to better manage and understand your human resource risks walking through the doors. Also remember that the information you gain through the pre-employment process, you are obligated to act on. The other key factor to consider in your design process is where the medical is actually timed within the recruitment process. So the cost, timeliness and intrusiveness impact when you insert the screen into your recruitment process impacts the candidate's impression of you and impacts how effectively you can use the information that you obtain, and in turn impacts how you can use this information. So for example, if you do have an expensive, thorough pre-employment medical program in place and you're using that as the very last step in the process, it is very clear to the candidate, if they are not getting employed, that it was due to that medical. You are also then subjected to going back to your recruitment pool to identify suitable participants to then start the process again, as opposed to inserting a pre-employment process earlier in the recruitment process. If it is affordable, if it is timely, it can not only set you up to have a broader recruitment pool, it can actually ensure that any additional steps you're getting the most value out of. So we do have a number of clients who use the online assessment early on. They may still default to going to a face-to-face clinical assessment. However, because they've done that online assessment first, that person is fully prepared for that online assessment. We know that they have met the basic minimum requirements to progress to that point. We know that if they have a pre-existing medical condition, they should get an up-to-date scan. They should get a letter from their specialist or their GP. We can coordinate that prior to them getting into that forum so that you can get the absolute most out of that forum with the doctor. There's also occasions where we've been identifying people that have exclusions based on a questionnaire, which completely avoids you having the unnecessary cost of that expensive medical process. And of course, there's also roles that are suitable for a questionnaire as a standalone, which once again is able to give you a really timely and cost-effective indication of that level of risk without all of the obligations and the downside that we've spoken about. So the final takeaways we'd like you to walk away with today in relation to reviewing your internal medical practices is, number one, to get your cost risk appetite aligned. Number two, to invest heaviest in the design of your program rather than the delivery. Number three, to ensure your assessments are aligned to the inherent requirements of the roles. Number four, to capture information as data and to systematise the process as much as possible. Number five, to adopt a rigorous quality assurance program. And number six, conduct continuous review to ensure program currency and effectiveness. Obviously, investing in a third-party provider to coordinate medical programs enables you to share the risk and protect information exchange. It also gives you access to a broad range of health professionals of varying skill sets and expertise, and you can benefit from volume-driven buying power and economies of scale. It also goes without saying, DHS would be delighted to help you out if this is of interest to your organisation and are happy to offer an obligation-free consult following this webinar. Just get in touch with Christine Hauser, our Business Development Manager, and she'll tee up a suitable time to start the conversation. And I will pop her details up on the screen shortly. But in the meantime, we have consumed our 30 minutes, but if anybody does want to stick around, we have got a couple of questions that have been coming through. So I will just ask Rebecca if there's anything that we need to address prior to closing out the session today. So it looks like Rebecca is having some audio issues. So what we might have to do is take a note of the questions that have come through and contact you back afterwards. I hope that you have found some value out of today's session, and please do not hesitate to contact us if you'd like any further information. My contact details and Christine Hauser's, our BDMs, are up on the screen right now. So thank you very much for your time and your interest, and we will look forward to speaking with you in the future.